Cody Richardson, Capella University, Nursing FPX4010, leading people, processes, and organizations in interprofessional practice. Johnson 2013 states, reflection is necessary to determine how one learns and one thinks, makes sense of information, thinks critically, views problems from varying perspectives, develops new insights, bridge theory and practice, and understand one's strengths and weaknesses. Nurses are not robots, and without self-reflection, it will be impossible to become a highly skilled nurse. Unfortunately, this concept is not directly taught in nursing school, but it is the responsibility of nursing professionals to embark on this journey in their own respects. Going forward, this reflection will evaluate a personal experience regarding interprofessional collaboration experience. Several days ago, I had a 92-year-old male patient who had been admitted for bilateral lower extremity cellulitis and bilateral pedal edema. For HIPAA reasons, the patient will be referred to as Joe. Prior to admittance, Joe had been experiencing symptoms consisting of pain, weakness, fatigue, leg swelling, and dyspnea on exertion for several weeks. Cellulitis and lower extremity edema had resolved in about 5 days. Joe was feeling stronger, and his hospitalist team felt he was ready for discharge. At this point, he was considered medically cleared. Joe had one major barrier, which I considered a hurdle that must be faced before he could be safe to leave. About 6 months ago, Joe and his wife lost their home to mold and were currently living out of their car. When they had enough money, they would stay at a motel, but were currently in between Social Security checks. Joe would not admit that he was worried about sleeping in his car after discharge, but it was apparent by his body language that he had concerns. As a patient advocate, I felt it would be my duty to ask the social worker to delay Joe's discharge for another night. The social worker's response to my request to extend discharge was, "Not everyone can get a hot meal in a cot." This comment was not expected and disturbing to hear from the social worker whose focus is to provide safety for patients and help to provide stability after discharge. I continued to push for a later discharge and explain Joe's situation further to the social worker. After an unchanged opinion by a social worker, I notified my charge nurse, who prompted me to speak to the hospitalist team. The hospitalist team agreed that Joe would benefit from an additional night in the hospital, but he would have to be discharged the next morning. Overall, I felt this was a successful collaboration because I was able to provide my patient with another night of stability. When my first intervention to call the social worker was unsuccessful, I looked towards different options to extend Joe's stay. Leadership guidance has been my main resource when situations arise which I'm having difficulty solving. Also, this experience helped me to gain rapport with the hospital's team and my coworkers as a patient advocate. The hospital's team was unaware of this barrier and appreciated my suggestion to extend discharge. When speaking with the social worker, I was unsuccessful in my attempt to explain Joe's situation in a way that seemed important to the social worker. It was apparent that the patient could benefit from another night in the hospital, but the social worker felt differently. During my conversation with the social worker, I had asked if we could find housing assistance or any type of support system to provide financial stability for Joe after discharge. The social worker reported that the patient was uninterested in assistance. In retrospect, I could have worked harder to provide an alternative to Joe sleeping in his car after his Social Security check for the month had ran out. In this situation, Joe's safety and long-term recovery goals were jeopardized because of a lack of stable housing after discharge. This elderly gentleman was struggling and did not have a means to obtain stable housing for himself. Joe was discharged from the hospital using a walker. His lower extremities were presenting with trace edema. He had a large wound on his anterior lower extremity, and he would have to continue taking antibiotics by mouth for the infection to completely resolve. At some point during his recovery, Joe would be living in his car, which presents with multiple safety concerns. For example, Joe was already a fall risk because of his weakness and his dependence on using a walker to ambulate. Ambulating in and out of the car multiple times a day will be very difficult for Joe and presents with an additional high fall risk. In addition, he has a chance to reopen the large skin tear on the anterior portion of his left extremity, which originated from him bumping his leg getting out of the car. Reopening the skin tear will require Joe to change the dressing every few days, and the open wound presents as a risk for infection. Changing the wound dressing will be difficult for Joe because of his age and limited mobility. His wife will be available to help, but Joe reported, "My wife is struggling with heart failure and swollen legs too." Most likely, Joe's wife is neglecting her health to support his. If she does not address her health issues, she will have to spend time in the hospital as well. This will leave Joe living in his car with limited mobility and even higher risk for an incident to occur. Readmittance within 30 days reflects poorly on a hospital. Medicare will not fully reimburse care if patients are readmitted within 30 days. Joe is a high-risk candidate for readmittance within 30 days, and readmittance will impact the hospital's revenue or profit during his hospital stay, as explained by Johnson 2017. Lack of poor collaboration, which occurred during Joe's discharge, has a high probability to negatively affect the hospital's fiscal year report and losses, as evidenced by Johnson 2017. Orthram, Spoden, and Wilkin 2015 performed a patient-based study to evaluate nursing workload and patient acuity. The results of this study evidenced that poor communication during collaboration will result in an increased nursing workload in the present or future. An unnecessary readmittance provides an unnecessary increase in workload for nurses and an unnecessary allocation of resources. Team empowerment is an aspect of collaboration which is undervalued and should be routinely practiced during healthcare worker collaboration. Team is only as strong as its weakest link. Empowerment and positive affirmations increase willingness to learn, increase communication during stressful situations, and a sense of support from staff members and leaders. UDOD and RACC in 2017 reference how a manager's positive and empowering workplace influence will create an environment which assists nurses' ability to accomplish their work. Having supportive coworkers and leaders which embody team empowerment is crucial to boost morale and provides nurses with a sense that they can depend upon other staff members. Empowerment provides self-worth to nursing staff, which in return increases productivity. When team empowerment is a leadership objective, goals will be achieved easier and quicker. Lynch, McCain, McCormick, and Brown 2017 describe an interdisciplinary theory called the Person-Centered Situational Leadership Framework, or PCSLF. The PCSLF relies on leadership to digest the competence, dedication, and skill of nursing staff which they are responsible for. For the PCSLF to be effective, the leader must be flexible with their leadership approach to ensure that it is congruent with the skill level of peers. Lynch, McCain, McCormick, and Brown 2017 explained that 5 factors consisting of interprofessional competence, commitment, interpersonal skills, clarity of value, belief, and knowledge of self are determined to develop the continuum of nursing staff. Leadership and nursing staff agree on a developmental level for staff members which ranges from S1 directing through S4 delegating, as explained by McCormick and Brown 2017. This process provides a precise understanding of role, creates a self-worth and achievement as staff members advance through the ranks. Through reflection, this example of interdisciplinary experience was largely successful, but experience is not without flaws. Jeopardizing patient safety after discharge can be recognized as a downfall of poor team collaboration, which will lead to inefficient management of human and financial resources. Leadership goals which improve interdisciplinary team collaboration can be achieved by utilizing PCSLF, which provides a sense of purpose and outlines. Leadership strategies such as team empowerment demonstrates adequate team effectiveness, which helps the team to achieve a desired outcome. The PCSLF has provided a unique approach to help teams achieve goals and support teamwork through staff rankings. As mentioned by Jacobs 2016, nursing professionals commit themselves to the well-being of patients, and a prudent nurse must learn to engage in self-reflection.